first, before I begin, I wanted to thank the Sylvia Gomez and Sylvia Partita, for inviting me to speak to you today. And my objectives are to really go over AADE's products and services for you so that you can understand how we can best serve you, and explain the AADE7 Self-Care Behaviors Framework that we use for working with people with diabetes. And then I'm going to outline the accreditation process for DSMES and prevention services. I probably won't go into as much detail on prevention as I will on self-management, but I will give you resources for follow-up on the prevention side. So the AADE Prevention Department is a separate department, and I don't work in there every day, but I do want to at least introduce you to what we have to offer. Okay, so who is AADE? We're basically a multidisciplinary professional membership organization, and we focus on improving diabetes care, and we do that through education, management, and support. And that support includes all of you, so it's very important for us to understand your needs as well. So we welcome that feedback and input. We have more than 14,000 professional members who are nurses, dietitians, pharmacists, exercise specialists, and others. I can't even list all the others. But you can see our members at a glance. Here, we're mostly women. The majority are nurses. The majority are CDEs or BCADMs, meaning we have those certifications in diabetes management. About 35% are dietitians, 7% are pharmacists, and I think that is growing. And I think our other health professionals, 6%, that is growing as well. Our president next year will be a physical therapist. So that's an example. We also do have services, products and services for paraprofessionals as well. And we are doing some things in that area to increase our offerings for paraprofessionals. But our mission is to empower diabetes educators to expand the horizons of innovative education, management, and support. And our vision is to have optimal health and quality of life for persons with, affected by, or at risk for diabetes and chronic conditions. So our leadership is basically, they're all volunteers, and they're elected. And we as professional staff at AADE guide and manage the association along with our volunteer leadership partners. Our board of directors is elected from the membership and is responsible for the strategic planning and governance of the association. I was previously on the board of directors for a couple of years before I went on to the AADE staff about 1.5 years ago. Our committees and task forces and liaisons initiate and execute projects that help us realize our strategic goals. So the following bullets here are just a description of some of the things that we're involved in. For example, professional development, advocacy, professional practice, research. We have 2 journals and a newsletter. We do awareness campaigns. We have special events, and one that's coming up this August, and every August is our annual meeting. We usually have about 3,000 people at those meetings. This year, it will be August 17th to 20th in Baltimore. Next year, we'll be in Houston, and the year after, we'll be in Atlanta. So we would love to see you at our meetings. We also do state and local conferences, and we have some special things we do for National Diabetes Education Week every year. Okay, so I wanted to get more into our specific products and services. And in order to do that, I divided it up into a members-only section and then what we have for non-members for everyone. So if you join AADE, you have access to more than 20 hours of free continuing education And our programs include the Diabetes Prevention Program model and how to be MDPP supplier. Those are our newest programs. We have free practice tools and resources, free patient handouts. We have, again, our two journals, the Diabetes Educator and AADE in Practice. The Diabetes Educator Journal is research focused, and the AADE in Practice Journal is more about helping people who are in practice every day and translating research into practice. If you are a member, you will get a discount to register for our annual meeting and for any of our product and event discounts. We also have a consultant that we use to answer all questions related to reimbursement, and that is a place on our website where you can submit questions called Ask the Reimbursement Expert. We have a map on our website that I'm going to show you later where people can search for accredited programs to find diabetes educators. But if you're a member or accredited program, you would have a listing. And anyway, on the right-hand side, I wanted to point out something new that you may not be aware of, even if you've been to our website in the past. And this is our new DANA. It's called Diabetes Advanced Network Access area. And what it is right now we've launched the app review, but in August, we're going to open up the entire website to members only. And it will be a place where you can find digitally connected company-supported devices and all the information you need about them. You'll be able to search peer-based reviews of apps, software, and technologies. You'll be able to do market research with your peers about new products and services and access evidence-based resources and product-specific training and education. So what I call that is our tech hub. That is where we take all the gadgets and things that our people with diabetes use. For example, all the pens, insulin pens, all the pumps, all the continuous glucose monitors, all of the insulin delivery devices, and put them all in one website and bring them all together for you, and that's where you can find all the information about all of them in one place. You don't have to search a separate website for the manufacturer. We just bring it all there for you. We also have some subscriptions and courtesy discounts. We also have a partnership with Capella University as well. Okay, also for members only, we have our My AADE network, which includes our state network, so you're connected to all the diabetes educators in your state through that. The communities of interest, I will show you in a subsequent slide, and as well as the practice area discussions. So these are some benefits for members only again. And here's what the communities of interest look like. So what you do is once you're a member, you can have access to any of these communities of interest. So there are Q&A communities of interest, resource communities of interest, and then there's a list of all of them in alphabetical order. And there's so many of them, they go past my screen here, but there is one for pharmacy, for example, that isn't showing up here. But once you can join any of these and have a blog or with your peers on those topics of interest. You can view threads that have been posted to the COI and just use that as a platform to ask your peers questions and network. The practice area discussion groups are a little bit different, but they're similar. These are the ones that exist right now. So if you have a special interest, say, in young adults with diabetes, there is a practice area discussion group you can go into and blog with them and post questions and comments and learn from your peers and network as well. Now, I've been talking about members, so I thought I should review our membership categories. I'm not going to go into a whole lot of detail because they're on the slides, but we do have different categories that you might want to look at. There's active members, associate members, see which one that you qualify for. We have international membership, industry membership, student membership, retired membership. And then we have different payment options. So we have installments, we have multi-year rates, and we have group discounts. So those are some things I thought you might want to know about. Now, our products and resources for everyone, so you do not have to be a member to access these. We do have the Dana app review area that is open to everyone. And this is where you'll find curated health applications across 5 categories consisting of 48 subcategories. So you'll find apps related to lifestyle, wellness, food, fitness, chronic conditions, and you'll have access to review them all, and not just diabetes-specific ones. There's a third-party vendor that goes in and uses specific criteria to rate the security of the app, the quality of the app, those sorts of things, so you'll get to see those published reviews. We also have educational tools, provider resources, CE program accreditation. So what that means is AADE is a provider of continuing education credit for nurses, dietitians, pharmacists, nurse practitioners, and PAs. And we also have career path certificates. So if you're not a health professional, a licensed health professional, and let's say you're a community health worker, we do have level 1 and level 2 career path certificates that you can obtain, which are online, and you can do them at your leisure. There's just a certain time period you need to complete them by. And at the end, you would receive the certificate of training. We also do workforce training. So if you're a director in your organization and you would like AADE to come in and train all of your staff on anything that we have to offer with diabetes, we can do lifestyle coach training for the diabetes prevention program. We've done several different trainings. So that is something that we do offer, and that is on a case-by-case basis. And then we have Living with Diabetes site on our website, which has resources for people with diabetes and interaction with peer support communities. We do meet with them regularly, and we share different efforts. For example, we worked with several other organizations after the hurricanes to work on resources and supplies for people with diabetes in affected areas. We also have a language paper that you'll find on our website, which started a campaign around the language we use with our folks with diabetes that we support. And so we're going away from all of our publications, resources, webinars. We're really trying to be careful with the language we use. We got away from the use of the word diabetic. Instead, we like to say people with diabetes, or person with diabetes, or individual with diabetes. So that's just another campaign that we've started engaging in this past year. So here's just a quick look at the tools and resources page for people with diabetes, who can go in and click on these links and find resources for example, on lifestyle, on taking insulin, on self-management, holiday eating guide, peer support. There are some Spanish resources here as well. Also for everyone, we have a sponsored prompt deck available to use with group discussions. And this is based on our AADE7 Self-Care Behaviors. It's available in English and Spanish. It's a very simple but effective guide for let's say, a facilitator to use with a group. So first, it includes sort of the content or the discussion, the Q&A, and there's always an activity that goes along with it. I think it's a nice tool, and it's downloadable from our website. So now I want to move into more information about our AADE7 Self-Care Behaviors. And you'll notice that it's trademarked, and we actually license our curriculum to other organizations to use on their platforms, because this is a well-known framework for self-management. There are 7 areas of self-management, self-care behaviors. They're healthy eating, being active, monitoring, taking medications, problem solving, healthy coping, and reducing risk. And I recently spoke with a program that was applying for accreditation for their diabetes self-management education services. And what they told me is they had offered what they call diabetes education before becoming accredited, but the process of accreditation and using this framework really gave them the structure they needed to make it successful and to take it to the next step. So that is something to consider. So what is the role of behavior in diabetes education? Well, there are national standards that have content areas focused on knowledge and skill, and educators should be measuring outcomes. But what we decided years ago is that those outcomes really that are unique to diabetes education are behavior change outcomes. So that is what the AADE7 framework helps with, and they exist as part of an outcomes continuum. Which by that I mean there's immediate outcomes, could be learning, knowledge, or skill, but then that doesn't lead to anything unless there's behavior change. And then once behavior changes, it can lead to improved clinical indicators such as A1C, and that in turn will improve long-term outcomes or improved health. So that's kind of the framework of where the AADE7 started, and you can see this publication is from 2003. So we're a long way from that, but we're still using the same framework because it has turned out to be extremely effective. So just wanted to go a little bit more in depth into the AADE7 framework and define what's under each of these categories. And on the right here, you'll see a picture of our curriculum. We do publish a diabetes education curriculum based on the AADE7 Self-Care Behaviors. You can obtain that through our website. But really, under healthy eating, it's mostly about understanding food and how it affects blood glucose, how to plan meals, how to choose what we call good food, well, you know, the proper foods that will help control diabetes. Being active is really about the importance of activity and weight management and blood glucose control. Monitoring is being able to understand the results of testing and how to monitor glycemic levels. Taking medication is understanding how and when to take the medications and how they work. Problem solving involves mostly making impromptu decisions, because we know that diabetes is self-managed 99% of the time. They only see healthcare professionals or others a very short amount of time. So they've got to make these impromptu decisions about food, activity, and medications every day. Reducing risk is about reducing complications and improving quality of life. And then healthy coping is about identifying and overcoming psychological and social factors. And that could be depression or stress or even diabetes distress. So what we offer around, also to anyone, these are downloadable from our website, is the self-care behavior tip sheets, we call them, that you can download and use with your people with diabetes that you're trying to support. And there's one of these for each of the 7 self-care behaviors. I've just included the one for being active up here to give you an example. And so feel free to download these. They also come in Spanish. So when you start to use the AADE7 framework, you're going to look at all of the behaviors side by side, and each person's needs will be different. But most people who are newly diagnosed tend to focus on the healthy eating, being active, and monitoring. And then the problem solving and healthy coping need more attention later, and they are basically building blocks for positive outcomes in all areas. You want to determine which behaviors are relevant for each individual based on their choice, their readiness to learn, the impacts of their condition, their whatever resources they need, and what barriers they have. So this framework really promotes individualization. You need to collaborate with the person with diabetes in order to set effective goals, and then discuss behavior change. You're going to give them knowledge to help them develop skills, but then the individual has to decide on the actions and set the specific goals that they need to reach. And the participant is the one who sets the priorities. The educator follows and guides them. In order to assess and overcome any barriers, we look at cognitive barriers such as attitudes and beliefs. We look at social support or lack thereof. We look at financial support, financial barriers, lack of resources. We consider how demanding their medical regimen is, whether they have any physical issues such as low vision, and always, always safety comes first when we're educating folks. We want them to be safe with all of their management. And how we address barriers is to identify steps to achieve the goal. So we start with kind of baby steps and we progress. We adjust the plan details, and then we develop strategies along with the person to help them. For example, how to learn to remember to test their blood glucose or to take their meds. So here's a quick case study on assessment and intervention using this framework. So the behavior is taking medication, and the current behavior is that this person is missing their medication often. So we've identified that the barrier is it's just too hard to remember to take their insulin at bedtime. So what we do is we consider with them could we change the schedule of the timing of their insulin? For example, we use this as a discussion and problem-solving strategy. So we figured out through discussing this that this person always watches a nighttime TV news program. So one of the solutions could be just to arrange to take the insulin right before that program starts. And you want to evaluate the goals at baseline, continue to evaluate throughout, customize the goals to the individual, and remember that behavior change needs to be practiced for at least 2 weeks before you can really reevaluate, and that behavior change is different from acquiring a skill. It is an actual change in behavior and not just a skill. So it's really a lifestyle change. We also make available these goal sheets that you can use to track goals in your setting if you wish to, or you can make your own tracking. All right, I'm going to move on to accreditation now. First, I'm going to go through a little bit about prevention, and then we'll talk about DSMEF. So the Diabetes Prevention Program is a national program that was administered through is administered through the Centers for Disease Control. It started as a research study in the late 90s, and was done in 27 centers across the country. It had more than 3,000 participants, and 45% of those participants were from priority populations with an increased risk of developing type 2 diabetes. And what they mean by that is certain ethnicities listed below have a higher incidence of type 2 diabetes. So they make sure to include a good portion of those folks in the study. All the participants were overweight, and all of them had impaired glucose tolerance, which is now known as prediabetes. So the results of that study were that an intensive lifestyle modification program with 7% weight loss goal and 150 minutes of moderate physical activity per week reduced type 2 diabetes. There was a 58% reduction in the development of diabetes overall, and a 71% reduction for people over 60, which is huge. And it was true for all ethnic groups, all socioeconomic statuses, for men and for women. And even after 10 years, we showed that the benefits persisted over time. So this is the evidence that's the basis for the current diabetes prevention program. So when they translated this research into practice, they started DPP in community settings, and they were just as successful as the interventions in the clinical setting. They started in small group formats and noticed they were just as successful as one-on-one coaching. And of course, you can see more people in small groups than you can in one-on-one. They trained, the trained lifestyle coaches did not need to be physicians, nurses, pharmacists, RDs, or CDEs. So that led to training for what we call paraprofessionals or non-professionals as lifestyle coaches. And we do include them in our lifestyle coach training as well. So when you look at having a group format, doing it in a community setting, plus having a diversity of lifestyle coaches, that reduced the cost to a third of the cost of the research study. Okay. And while some things changed, many things stayed the same. The program duration stayed at least 12 months. So you can see that's how long it takes to achieve those goals. The program intensity consists of at least 16 weeks of weekly 1-hour sessions and a maintenance period of at least 6 1-hour sessions delivered at least monthly in the second half of the year. Weight loss needed to be at least 5% and moderate activity at least 150 minutes per week. And they were accepting a screening or blood-based test to accept people into the program. Okay, so where does AADE fit in here with the DPP? So from 2012 to 2017, AADE was one of the 6 national organizations to receive a 5-year cooperative agreement from the CDC to scale and sustain multi-state networks to deliver the evidence-based lifestyle change program known as the National DPP. The CDC has awarded AADE a 5-year cooperative agreement to bring the National DPP to underserved populations with little or no access to diabetes prevention services. So we have just received that grant in the past year. And efforts under this funding include working with truck drivers and other at-risk populations, including Hispanics, African Americans, and Native American communities. And in this grant, this 1705 grant that we've just started, we'll be working with different partners, and they're listed here. Unidose US, Omada Health, which is a digital platform for DPP, Healthy Truckers Association of America, and the Bridgespan Group, in order to raise awareness, conduct screenings, expand coverage areas, and promote enrollment into this program. So we have been involved with the DPP since 2012, and we are continuing to be involved, although with every grant cycle, our focus changes slightly. So in order to receive full recognition for this DPP program, there are steps you need to follow. And it starts basically at the bottom of the pyramid with becoming a lifestyle coach for the Prevent T2 program. Prevent T2 is the current name for the CDC recognized program. And then once you have your lifestyle coaches in place, you can start a prevention program in the community, and you need to basically administer the program for at least 12 months. Then you can achieve either pending or preliminary recognition. And then once you reach the full 24 months, you can apply for full recognition. And at that point, you can also become a Medicare DPP supplier, because Medicare now covers the diabetes prevention program. Okay, so I'm not going to go into all the ins and outs of becoming a DPP supplier or starting a DPP program, but I will give you our email address for the experts at AADE is dpp@aadenet.org, and the phone number for them is here. We also have a data analysis program available to folks who work with us in our prevention department, called the Data Analysis of Participants System. So the CDC and Medicare require that you track data of your participants in DPP and report it at certain intervals, and AADE has that tracking system that's called DEAP. We also conduct Building Your DPP program workshops and lifestyle coach training throughout the year. So please call or email us, and we can walk you through all of that. The other thing I wanted to mention is that if you have a question for Medicare about becoming a Medicare DPP supplier, their email address is mdpp@cms.hhs.gov. And there's also a website that they have which really outlines everything you need to do to apply and to get preliminary recognition. The CDC has a website as well, so I would refer you to those, and we have links to those sites on our website. Okay, now I'd like to move into accreditation of DSMT programs. DSMT stands for Diabetes Self-Management Training, and that is the terminology that Medicare uses to be able to reimburse the program. AADE DEAP is up here also on the title, and that is our Diabetes Education Accreditation Program, DEAP. We've been an accrediting organization for CMS since 2009. The only other organization currently accrediting programs is the American Diabetes Association. And the ADA and AAD often do, we often co-present on webinars and things on our requirements for accreditation. So we partner a lot, we work together. There are only really minor differences between what each of us requires. We follow the same standards. So accreditation provides a structure for diabetes education services, as I told you before, but it also allows you to bill Medicare and commercial insurances that cover diabetes education. For the commercial insurers, you would need to check their requirements for coverage. They do tend to follow Medicare, but they may be different. So the first thing you need to know about accreditation is that there are 10 national standards that you will need to meet in order to qualify. There are structure standards, process standards, and outcome standards, and those are listed here as they're divided up. But basically, standard one is is all about the internal structure that you need to have in place. Standard 2 is just input from internal and external stakeholders. Standard 3 is evaluating the population you hope to serve with your program and making sure that your services are designed to meet their needs. Standard 4 means there needs to be an assigned quality coordinator that oversees the service. It doesn't run itself. There needs to be someone overseeing it to make sure that it's quality and it meets current evidence. And then there's a team, obviously, that will instruct and facilitate groups. There needs to be an evidence-based curriculum, and I have already indicated that we strive for individualization in the teaching that we do, and we provide ongoing support. We track participant progress through tracking different outcomes, behavioral outcomes, clinical outcomes. And then the last standard applies to quality improvement. There needs to be ongoing quality improvement projects in order to keep it up to date and to be a quality service. So AADE, well, I guess NCFH sent out a survey asking you what your barriers were to implementing or maintaining a diabetes education program. So I would like to address the barriers that came up through that survey as the last part of my talk here. And just know, I want to go back to the 10 standards. We do webinars for our coordinators, and we will be happy to work with you to understand each of these in more depth. We have a lot of information on our website about them. If you have any questions, you can definitely reach out. But let's just take these barriers, each one by one. I wanted to address them for you. So the first one was we don't have enough information about how to implement an accredited program, or we don't have the right staff, we don't have the money, or it costs too much, the program is too labor intensive, we don't have the appropriate systems for tracking the participant progress, training of staff is too time consuming, and there are too many sessions required. So these were the barriers that came up through the survey. So I'm just going to go through one by one. And by the way, the end of the survey, there were 25 people who responded. Okay. So I'm going to address the first and third barriers, which were about not having enough information to know how to apply and about the pricing. So this is on the left, a screenshot of our website where we have our information about applying for accreditation. And the first red circle at the top shows you how to get to this page. So you would go to practice, the practice tab, then click on diabetes DEAP, and then click on applying for accreditation. On the right-hand side are the related resources, and all of those pages on our website, these are links to get you to the other pages to give you information. The one that I would highlight is the last bullet called interpretive guidance. That is the one that walks you through all 10 standards and tells you what you need to have in place. So if you follow that interpretive guidance, you should be able to come up with your application pretty easily. We also have 3 sections on the website where you can see here we have the initial application pre-work, what else do you need to know, and then we talk about the application process. And you can contact us at any time throughout that if you need extra help. On the right-hand side of the slide, I've included our initial and renewal application fees. But you have to realize $1,100 might seem like a lot, but that gives you accreditation for 4 years. So really, when you look at it, it's only about $275 a year. And if you are able to bill for just a few patients, I mean, you can recap that $275 pretty easily. Community sites are free and branch locations are $100 per location. And there is a section of our website that explains the differences between them. The second barrier was not having the right staff. So I wanted to just review with you what staff are required and who can be part of the team. So once accredited, an RN or pharmacist instructor can bill under an organization's NPI. A dietitian is considered a billable provider, so there's really no question that a dietitian could bill for MNT, but again, need to be part of an accredited program to bill for DSMT. You do not need to be a CDE in order to provide and bill for DSMT. That is a myth that I hear a lot. You do need to have at least one RN, RD, or pharmacist on staff in order to become accredited. But community health workers can be part of the team. And so you could have one RN or one RD or one pharmacist, and the rest of your team could be community health workers. That would work fine. If you're an FQHC and you're doing only individual visits, you can do DSMT on the same day as a mental health visit. You just can't do it on the same day as a medical visit, as a medical visit. The quality coordinator does not need to be a health professional. So anyone can be, anyone with experience, for example, managing a program or being a clinical manager or working with a chronic condition, for example, could be a quality coordinator. The barriers listed, number 4 and 6, were about labor intensity and staff training, so I wanted to address that here. So accreditation requires that one professional instructor does all the intake assessments and comes up with the education plan, and then the community health workers can teach the groups or do follow-up coaching and support. For professionals, we require 15 hours of diabetes-related CEUs annually, but generally they're required to get these CEUs to keep up their licensure anyway. And we offer many options to earn CEUs for nurses, dietitians, and pharmacists. We're an approved accrediting body for all three. For community health workers or paraprofessionals, we have training that their training would also count for their CEU requirement. So if, for example, they had the Stanford or the DEAP training within the past year, that would count for their 15 hours of CEUs. Or they could take advantage of the AADE Career Path Level 1, that would count. And we have competencies listed on our website to be used to develop organizational training if you'd like to do your own training. We also, as I mentioned before, offer workforce training, lifestyle coach training, and either of those would count towards the CE requirement. A couple of other barriers were not having a system for tracking and the number of education sessions required. So as far as tracking, many systems either use their EMR or just an Excel spreadsheet. So you don't have to have anything fancy to track things, but we do offer AADE7 system in our basic version. It's free. That's a separate software system that's hosted by a third-party vendor where you can use for your EMR or tracking. Also, for the number of education sessions required, there might be some confusion as to the actual coverage by Medicare and what we require for accreditation. So Medicare covers up to 10 hours of education, 1 being individual and 9 hours being group, in the year after, in the 12 consecutive months after the person starts their DSMT training. However, the standards changed in 2017, and are more geared towards individualization versus a set program. So what we used to see is, okay, Medicare covers 10 hours, so we're going to have 5 2-hour sessions, or we're going to have, 8 1-hour sessions and 1 individual and a follow-up or whatever. So people would design their sessions based on what Medicare reimburses. However, you can actually define what completion means for your program, and you can design it based on what works for your population. So for example, I used to run a program in the Twin Cities of Minnesota. We had a lot of refugees that we saw there. We had a lot of urban population. They were working 2 and 3 jobs sometimes. They had difficulty with transportation. So we decided that they were having difficulty coming to a lot of hours of education, so we individualized it to what was most important to their needs at that time. And that's how we defined completion. So just know that there's no set number of education sessions required. You can design that, whatever works based on your population. And I wanted to show you this map that I mentioned earlier. This is on our website, and it's available to anyone. It basically is ADA and AADE gives our list of accredited programs to the CDC, and they send us back the information on the map. So the CDC keeps this map up, and the last time it was updated was at the end of April. But if you notice at the bottom, there's a place to check all the AADE sites and the ADA sites. The AADE sites come up as a yellow little button, and the ADA sites are purple. You can see there's a lot more purple because they've been accrediting programs for a lot longer than we have. So there are more of them. But this is how you would search to find out the accredited programs in your state, for example. You just you can put in the name of the state under name and location on the upper right-hand side of the map, and it will zero in on your state and the programs listed there. So lastly, I wanted to go over our DEAP resources. So we do have a specific email address called DEAP@aadenet.org. That is our inbox for the accreditation program. We also have a main telephone number that has a phone tree that gets to us. I mentioned before we have free monthly webinars for our coordinators. We have an interpretive guidance that I showed you for each standard. We have an online application, and when you apply for accreditation, we include an hour-long phone interview with me to review your application, and it's not a pass or fail. It's just a friendly look at your application and talking about some things that you might need to tweak in order to make it pass, or I don't mean pass, but to make it better and to be able to approve it. That's where we go over next steps after the approval happens, that sort of thing. And we also like to get to know our programs just a little bit. That is our connection with you. And the other thing we can do for you is we can help you network with other health centers who've been successful in getting accredited who are similar to you. All right, well, that is all I have. So I think I'm ready to entertain any questions.
Okay. All right. Thank you very much, Jodi.